Hello, today we're going to be talking about the cardiovascular case study. We're going to look at aortic aneurysms. I'm your presenter, Martha St. Jean from our own university, and this is the Advanced Pathophysiology course with Dr. McDonald. We're going to be looking at what a thoracic aortic aneurysm is during this presentation, how it is treated, what is the prognosis, and what are the comorbidities or risks? Thoracic aortic aneurysm, or TAA, is a dilation of a weakened localized area in the arterial wall of the aorta, specifically at the thoracic area. Meet me. She is a 66-year-old black female from West Indies. She is 5'7", 135 pounds, well-groomed with guarded gait. Her shoulders are bent slightly forward and maintains hands over mid-chest upon standing or sitting. She is pleasant and in good spirits. Past medical history for me includes a post-surgical repair of her thoracic aorta aneurysm. She has a history of palpitation and hypertension. Post-surgical atrial fibrillation as well. Her social history, she's a widow, lives with her brother and his wife and their 2 adult sons. And since the surgery, she sleeps on a hospital bed in the living room to avoid climbing stairs. During the past 4 months, Me has been recovering from open thoracic aortic aneurysm, TAA, repair. Prior to this, she was diagnosed incidentally with TAA upon visiting her physician complaining of palpitation and high blood pressure. Due to the COVID virus, she found herself displaced from her home in Haiti. Originally, stress and anxiety was the focus of the exam. However, on further examination and conclusive tests, it was discovered that an aneurysm was present between 3 to 5 centimeters in diameter in the posterior ascending aorta. The patient was placed on antihypertensive medication and given instructions to avoid stress and exertion. For the next 3 years, Miss Me was followed periodically with CT scan with contrast to monitor changes or growth of the aneurysm. And in 2023, on follow-up, it was determined that a prophylactic repair was necessary to avoid spontaneous rupture of the aneurysm in spite of the slow growth. The surgeon determined, due to her frailty and emotional stress, due to her abrupt departure from her country and separation from her adult children and grandchildren, it was prudent to proceed with the repair to avoid a potential spontaneous rupture. Family history of her mother with gestational hypertension, which later developed into hypertension and congestive heart failure. Her mother had a pacemaker and she smoked most of her life. She was diagnosed with cirrhosis of the liver and the cause was undetermined. She died of complications of osteoporosis after a spontaneous fracture of the femur at the hip joint at age 79. Mrs. Me's father had high cholesterol and high blood pressure. He suffered from dementia and had hip replacement after a fall. He also had a pacemaker and died from the disease process of dementia at age 84. Let's review the systems, vital signs. She's 5'7", weighs 135 pounds. Her body mass index is 21.1. Blood pressure is 122/80, and heart rate is 79 beats per minute. Her pulse ox is at 97% with room air and at rest, and her temperature is 98.7. Her current medications include amoxicillin 500 milligrams to be taken prior to dental examinations or appointments, and she used to take 4 tabs by mouth an hour prior. She takes aspirin daily, 81 milligrams, loratadine for allergies, 10 milligrams daily. She takes magnesium hydroxide, 600 milligram chewable tablet daily. Metropolol succinate, extended release, 50 milligrams, takes 1 tablet daily for hypertension. She's on Tylenol, 500 milligrams, 2 tabs twice daily for pain, vitamin B12, B6, and C, 250 milligrams of C daily, and gabapentin, 300 milligram capsules, 1 capsule twice a day as needed. Her skin is supple, good turgor, multiple nevi spares throughout her body. Her mid-sternum surgical wound is healing well and with intact adhesions, slight redness at the lower end. Her head, ears, eyes, nose, and throat, head symmetrical with no lesions or abnormalities, no adenoma was palpated, eyes are perla, pupils are equal, reactive to light and accommodation. Her ears are clear with no exudate and remarks visible. Nose is patent with no deviation of septum. Throat, no redness, soreness, or inflammation, no discomfort or trouble swallowing. Her lungs, her respiration rate is 18. Lung sounds are clear. Upon inspection, there is a slight swelling at mid-chest due to surgical wound. Her cardiovascular system. So upon inspection, patient was guarded during palpation. She stated she was fearful of surgery as she has wires around the bone. She was assured that her healing is going well and she should not fear for her bone structure at the mid-chest. S1 and S2 were noted on auscultation. Orthostatic blood pressure was noted, slight vertigo upon standing from sitting or sitting from lying. Currently treated for essential hypertension and to avoid recurrence of aneurysm. Her musculoskeletal, she has generalized weakness. She has a shuffling gait, weakened bilateral arms with diminished muscle tone, prescribed limitation of the arms as she is unable to raise them over her head. Neurological alert, she's alert and cooperative, oriented to person, place, and time. The cranial nerves are intact between 2 and 12. Mental status, she states that she still feels apprehensive and hypervigilant because of the precautions she had prior to surgery and the precautions she currently has to adhere. Her pain level, she states that she has pain at the site of surgical incision. The rate of pain is 5 from a scale of 1 to 10, with 10 being the worst. She states she feels a heaviness off and on and with movement. She says she cannot sleep on right or left side, but she feels a tugging with the pain at mid-chest. She takes acetaminophen, and it does help with pain. She had stopped gabapentin, but was advised to reduce acetaminophen to 3 times a day and take gabapentin 2 times a day as needed for pain. She takes naps during the day if she feels too much pressure at the site of incision. This does help relieve the pain. So what is thoracic aortic aneurysm? An aortic aneurysm are the second most common aortic disease and is the ninth leading cause of death. Defect in the medial layer of the aortic wall develops in association with turbulent blood flow. This can be related to bifurcation or atheroma. Trauma, such as from a car accident, may result in tearing tissue. Disease such as syphilis may also cause damage of the atrial wall. Over time, the affected area will enlarge with continued dilation. Eventually, it can rupture. Studies show a slightly higher incidence of TAA in women than men. TAA can remain asymptomatic and may rupture suddenly, leading to life-threatening hemorrhage with a high level of mortality. And some studies suggest that there is a disparity between male and females diagnosed with TAA. More often, females do not have clinical comorbidities or health risks such as heart disease, diabetes, concurrent smoking, chronic obstructive pulmonary disease, or chronic renal dysfunction. So TAA is usually treated through surgery to repair the aneurysm, and this could be prophylactic or therapeutic. Pending surgery, it is of critical importance to maintain blood pressure at a normal level, preventing sudden elevations caused by exertion, stress, coughing, or constipation. In some cases, small tears may occur before a major rupture. These need immediate surgical repair. Surgical repair with resection and replacement with a synthetic graft can prevent rupture. This is a quote from Van Meter Hubert, 2023. The use of B-adrenergic blocking agents is widely used to maintain the aneurysm until surgical repair is needed, as was in the case of Miss Me. This treatment can even negate the need for surgery. So what is the prognosis of TAA? Studies show close to 8% mortality rate among females with open TAA surgical repair. Also, 15% of adverse events was noted among females after aortic aneurysm repair. Some of the comorbidities or health risks of TAA is mainly hypertension. The increase of volume within the aorta can create a tear in the atrial wall, similar to that of a garden hose. A weakened vessel is more likely to thin and cause the pocket of fluid to create a bulge. Milwicks and Rivera in 2019 note a 20% of cases show a genetic predisposition with the presence of single gene mutations. Therefore, this can also be a genetic issue. More than 15 genes have been thus far identified that harbor highly penetrating mutations predisposing to thoracic aortic disease. The risk for TAA increases with age, and it is associated with degenerative pathological changes. And research notes a disruption to the proper response to hemodynamic load in the aortic wall. Related to genetic alterations. So having a genetic testing upon diagnosing is important just to maintain the studies and the research with accuracy. So here are my questions for you. What are 3 systems that are affected by me's current condition? How can each be addressed? What education does me require? And what referrals would be beneficial for me? Review this and post your answers. Thank you.